Well, hello and welcome to today's talk. I thought I'd talk a little bit about personality and I guess what we call personality disorders, which is a interesting term, isn't it? It does definitely carry a little bit of, let's just call it weight. I think it's a term that is used, as an attempt to simplify a complicated picture. It's an attempt to try and label a set of characteristics, and probably the goal is to increase professional communication and to have a good diagnosis that we can use to treat it and to see how it goes. But definitely there's a sense that some people get offended with the concept of a personality disorder. It can be used pejoratively. It really attacks like the personality, the person, and that can be very unhelpful, and that's often why you will have heard me talk about it on this channel, and I'll talk about it to patients, that let's not focus too much on the label, let's focus on the narrative and on finding out what works. Now, having diagnoses can be extremely helpful because it can guide your treatment in terms of choosing what to try. I wouldn't try an antidepressant for someone who's psychotic, initially at least, and I wouldn't do vice versa. So having the diagnosis of depression or psychosis will help guide what treatments to try. But we also have to acknowledge the brain is very complicated. People have paradoxical reactions to medicines all the time, and if your treatment is making things worse, you've got to be adaptable in psychiatry. Definitely, you've got to be ready to change. Of course, there are patients that fit the models that we have, but there are a lot of patients that don't quite fit the models that we have. So, a model is exactly that. It's a model. We have models on how we think the brain works and how we think the brain responds to different medications. But these are models and they don't always hold up to reality. And at the end of the day, no matter what textbooks you've read, no matter what models you use, at the end of the day, the patient in front of you is the reality of the situation. So if they're saying, and it's corroborated with collateral, and it's not fictitious or anything, if they're saying that something isn't working or it's making something worse, we've got to adapt, even if it doesn't necessarily fit our models to do so. All right, starting off with a tangent there, sorry. But coming back to personality, look, I've had some interesting experiences over my first year as a registrar, and people using the term almost pejoratively, as an attack sometimes, and sometimes it's unconscious. It's a way of kind of, if you've had a difficult interaction with a patient and you're angry at them, then it could be an unconscious drive to want to punish them, and saying they have a personality disorder might be doing that. Now, I'm not talking about anyone in particular. I've just kind of seen this stuff leak into conversation. And so the intent around when we're talking about personality disorders, the intent of how you speak about the personality disorder is very important. But I guess I wanted to talk today about a more helpful way to think about, let's call it personality disorders, because what is a personality disorder? Okay, like if you're using the DSM, it's a set of symptoms, and if we're talking about borderline personality disorder, the symptoms are usually related to emotional dysregulation, self-harming, suicidal ideation, up and down, very up and down relationships, up and down mood, feeling really happy, feeling really sad, changeable over minutes to hours, and a sense of emptiness, so issues in the way they see themselves and that kind of thing. And it's pretty, well, it's, some people meet all the criteria, some people just meet a couple of the criteria, and it's kind of like, I guess what I'm trying to say is it's more helpful to, instead of just call someone borderline personality disorder, understand what is their attachment style and what are their defense mechanisms. because those are the things that, you know, are probably causing some functional impairment, and that's the goal of treatment. You always got to ask, what is the goal of treatment here? Often it's very vague, and you've got to work hard with someone to figure out what is the actual goal. Is your goal to be happy? Is that realistic? Like, with what you've been through, if you've gone through horrible trauma, it's usually not the goal. Usually the goal is to relieve suffering to a degree, and often the way to do that, if you want a more kind of concrete goal, is to return to some level of function, to belonging into a social group, returning to work, whatever it is, connecting with a family member that you haven't been in touch with for a while. And so once you identify how someone's personality is causing an impairment towards achieving their goals, which is usually relating to their attachment style and their defense mechanisms that they use to manage their anxiety, once you understand those, then you can target treatment better. And I don't care what you want to call it. You can call it borderline or what, emotional unstable or avoidant or dependent. As long as we agree on what the problems are, maybe that you have, well, let's pick a defense mechanism. Maybe that you tend to, let's say you tend to self-harm when you're feeling overwhelmed, right? And okay, we've got a defense mechanism which is attacking the self. It's not a mature defense mechanism. You know, there are ways to manage anxiety that are more, you know, the word we use is mature than others. And the mature defense mechanisms are good to know. So I'll just make a tangent to talk about them right now. They're things like sublimation. Sublimation is using the negative, anxious energy from one thing and putting that energy and anxiety into something healthier. Okay, so for example, feeling really anxious about an upcoming speech, and so you're going for a jog to help release that anxiety. That's using one energy into one thing and feeding it into a healthy behavior like going for a jog. So the other, you know, humor and altruism. So you know, having a horrible trauma causing anxiety and then helping other people who have been traumatized to help relieve their anxiety. Altruism can also be a mature mechanism. You want to make sure it's not leading into avoidance. You don't want to do altruism to the point where you avoid your own therapy. But anyway, so you know, you can Google all the adaptive or mature defense mechanisms. They're good to know, and it's always good to kind of pick what you're doing. So I definitely have some immature defense mechanisms, as we all do, because we all have our breaking point. And I think I tend to project, do projection. I put, you know, problem I'm experiencing myself onto someone else unconsciously, and then I realize, oh, actually that's me. I'm the one that needs to work on that. That's not their fault, that's my fault. So maybe you guys do that too. You know, that's an interesting thing to put in the comments, guys. Why don't you comment below what defense mechanisms you think you use? And the key thing is you're probably wrong because they're unconscious. Okay, you have to work on them with a therapist to kind of work out what they really are. Anyway, getting back to the kind of thinking about attachment and defense mechanisms. Yeah, it tends to be a bit more helpful to think that way in terms of patients, because then instead of saying we're just going to fix your personality, which doesn't really mean anything, we're going to target what are the problem behaviors and what are the therapies. So if you're using self-harm to manage your anxiety, well, what's a good treatment for that? Well, it's dialectical behavioral therapy, okay? Which, if you haven't heard of dialectical behavioral therapy, my gosh, you should have. It's an excellent evidence-based program for people who have kind of symptoms like that you would see in emotional unstable personality disorder or borderline personality disorder. And the kind of concept of it is you're mixing the wisdom of thousands of years of Zen Buddhism and mindfulness, and you're mixing that with the last 100 years of psychological behavioralism, and so it focuses on distress management and mindfulness and interpersonal relationship management. and emotional dysregulation, of course. So it's a extremely helpful program, but it ain't easy. So that's the thing with anxiety, guys. Like, anxiety is one of the mental health symptoms that has the largest response to treatment. But the treatment of all the therapies is one of the hardest to do. So it requires the most work and can have the most benefit. That's very important to remember. So psychosis, yes, there are some psychotherapies for psychosis, but really the majority of improvement is done via taking a pill or taking a depot medicine, which isn't really that hard when you compare it to doing intensive psychotherapy for your anxiety. Now, I'm simplifying, right? If you're getting side effects from the antipsychotics and they're not really working as well as you'd hope, then yes, it is difficult to manage psychosis, of course. But you get the point. You've got to do a lot of cognitive effort for psychotherapy and DBT versus just taking a pill, even though it's not that simple for psychosis. So that's my little rant around defense mechanisms and attachment styles. I guess we didn't really talk about attachment styles, but I have a video on it. It's important to understand because a lot of people have a disorganized attachment style, right? Attachment styles really we discovered the research around attachment styles really started in the early 1900s. There was John Bowlby, Mary Ainsworth, and a couple of other psychotherapists, and they just noticed that like babies as young as like 2 or 3 years old had different ways of relating to their caregivers, and the different styles really do follow you through life. So if you were an avoidant child and acted disinterested to your caregiver, even though you would be anxious, you wouldn't go to your caregiver to get your anxiety relieved. You would hold it in. Those people with those kind of avoidant personality disorders do tend to have more somatization. So instead of engaging with the mental health symptom of anxiety, it'll manifest physically in their body. And that's a very underappreciated thing. I'm always saying anxiety is a physical health illness. It manifests in your body. You will have pain in the muscles from the tension that is unrelenting, and that's why strategies like progressive muscular relaxation techniques are really important, to learn how to relax your muscles under anxious tension. But again, that's heaps of hard work. But again, that's going to have there's a lot of positive outcome you can gain through doing that work. I mean, who really knows? But what proportion of migraines, guys, what proportion of migraines do you think are from a somatization point of, like, from a somatization cause? What proportion of migraines are really a manifestation of anxiety that is unacceptable? There are so many defenses around engaging with the anxiety that it manifests in another way, in a physical symptom. I don't know, and I'm very sure that there are plenty of migraines that are more biologically driven, but I would not be surprised if a substantial amount are a somatization disorder, and yeah, that would be interesting to know. If you guys have ever been anxious, that would be interesting to read and for you guys to see each other's comments around how does your anxiety manifest physically. All right, we all know anxiety and its cognitive manifestations. You get this horrible, heightened, hyper-aware, worry, and eventually a fight and flight response that can manifest as a panic attack. That can be how it kind of manifests mentally, but how does it manifest physically for you guys? Where do you feel the tension? And some people it's in their chest, some people it's in their neck. I know someone who gets really sore backs, and shortness of breath. Yeah. Look, that's kind of all that was on my mind. I guess we can talk more about anxiety in other videos if there's things you want to talk about. Put some comments down if there's other rants you want me to talk about. I haven't done a video for 2 months, sorry. I've been doing more of the shorts because that's all AI algorithm. I used an AI tool to take highlights from these longer chats and to make them into shorts. And that's a very cool tool. So that's what I've been doing. But my life right now is studying for an exam on the 1st of March. So I can't prioritize YouTube at the moment. I have to prioritize this exam because it is such a hard exam. And, you know, I've done a couple of practice exams and sometimes I'm passing and other times it's not clear, like I'm on the nose, and it's very variable and I need to increase. It just kind of depends what questions they ask on the day. It's all really tricky multiple choice questions. You know, it's what's the least incorrect answer, what's the most correct answer, sorry. And then they give you 5 correct answers and you have to be like, oh, what's the most correct one? So it's that kind of, and it's 3 hours long, and 180 kind of questions or 180 points. And it's just, I haven't had to focus for 3 hours straight for so long, and I feel like I've really been detrained since being a student at university. I've lost my ability to focus and get into flow states for long periods of time. And I guess the last thing I don't like about exams, I'm sorry that this video transitioned to me having a rant, but it's my video. Ha! The last thing I don't like about exams is that I'm studying for explicit, not implicit reasons. You get that? So there's 2 reasons to do things, the implicit drive and the explicit drive. Explicit is really, I'm doing it for other people, I'm doing it for attention, I'm doing it for numbers, I'm doing it for achieving a goal that's decided by others, which is what this exam is. You know, I have to do this exam if I want to progress in my psychiatry training. So my motivation is explicit, as opposed to implicit goals, which might be that I want to read this textbook on psychodynamic psychiatry, but that wouldn't be a good use of my time right now, even though that I would find that more interesting personally. It wouldn't be a good use of my time right now because it's not examined in the exam heavily. So I have to not do what I want to study and study what the college wants me to study, which is fine, and I get it. We need a curriculum, we need a standard, we need monitoring. It's psychiatry. I'm aware of the history. We used to give people insulin comas and unanesthetized ECT, and there's all sorts of wacky historic reasons why, medicine needs monitoring. And I get it. So happy to do the exams, but it just means that I'm not, it just means that I'm working hard. And that's okay. It's important to work hard. Yeah. All right, guys. That's probably it for my rant today. I hope you enjoyed the chat. Please leave comments. I'm very curious to know your thoughts. And I wish you all beautiful days, full of love, full of connection, and I'll see you all in the next video. All right? Bye for now.